This is a limited OB sonography training for nurses that are scanning in the pregnancy resource centers. Now, some of this training may be a little different from site to site. So if some of the policies and procedures at your institution that you're going to be volunteering at differs, then you'll need to speak with your ultrasound coordinator about that. So today, hopefully, after you finish this presentation, you'll be able to answer all of these questions, okay? If you want to take a moment and pause and just read through these, that way you can have a good idea. And then at the end of the presentation, if you want to scroll back and read back through these so you know you're able to answer these. And if you have any questions about them, feel free to ask me or your ultrasound coordinator at your facility. Okay, first we're going to start talking in session 1 about the ultrasound techniques. And we can't talk about ultrasound without learning just a little bit about acoustic physics. Now, we're not going to go in depth like if you were in sonography school on physics of ultrasound, but you do need to know a little bit. Okay, so what is ultrasound? So if you're not sure, sound is characterized by humans' ability to hear it. So humans, we can hear sounds that are between 20 and 20,000 hertz, okay? Anything below that 20,000 hertz is too low of a frequency for us to hear, and it's termed infrasound. Anything above 20,000 hertz is too high of a frequency for us to hear, so that is termed ultrasound. So anything that is 20,000 hertz and above is ultrasound. But as you'll see later on, we're not able to scan using any frequency that's ultrasound. So medical sonography is performed with typically between 2 and 18 megahertz, which is million hertz, okay? But medical imaging with ultrasound, that's actually called sonography. Okay, so how do our machines produce ultrasound? So our ultrasound transducers, which are the things that you actually hold and you put on the patient's body, that's the transducer. It operates according to a principle known as piezoelectricity. And this principle states that some materials are deformed by an applied pressure and produce a voltage. And then conversely, also if there is a production of pressure, when an applied voltage occurs, it deforms the material. So lots of complicated, theories and stuff, but I'm going to get my pointer here. Okay, so essentially what happens in our machine is the electricity goes into our transducer and it hits, we're going to pretend like this green are the little crystals that are inside our transducer. So when the voltage hits the back of our crystal turns that electricity into ultrasound. Okay, and then it goes out and we scan in the body, and then the sound bounces back, so it echoes back. And when our echo sound hits the transducer, our transducer turns it back into a voltage. Okay, so that's how that works. Now these crystals are very delicate, so dropping that transducer can cause a degradation in the image, and it can cause black lines to occur, known as dropout. So hold on tight to that transducer and do not drop it. Okay, for most of your scans, you're going to be using a transabdominal probe, which you see here. It's curvilinear just because which mimics the shape, okay, the shape of the transducer that touches the patient's abdomen. But there's also a transvaginal transducer that you may end up using for your scans that are earlier than 6 weeks, 6 or 7 weeks, just so that they can see what's actually there. But the frequency on one of these curvilinear transducer typically ranges from 2 to 6 megahertz. Now the patients that are a little bit larger, you'll want to use a lower frequency. If they're a little bit skinnier, you can use the higher frequency to get a better image quality. Okay, it's important to know sort of the internal construction of our probes. So again, the power supply coming in from the wire, it hits all of the different little crystals, and then the sound goes out, returns back, and then goes back through that wire. So it's really important to pay attention to the transducer face, which is what actually touches the patient, to make sure there's no cracks in the housing and there's no showing of the crystals, because that electrical current can shock the patient. So we always make sure that we look at our probe, that there's no cracks on the front, and also that there's no frayed wire coming from the machine to our probe. And that's something that when we do our quality assurance testing, whether it's quarterly or biannual, that we will always, assure that that's intact. So is ultrasound safe? This is a question that has been asked ever since we've been using ultrasound to image. It has been used for more than 20 years. It is non-ionizing radiation, which that means, the ionizing radiation is what's used in x-rays. So the ionizing radiation can produce harmful effects, but there are no proven bioeffects using ultrasound, okay, over the more than 20 years that it's been used. Now, even though there are no known risks of ultrasound imaging, it can produce effects on the body. So when the ultrasound enters the body, it heats the tissues slightly. So in some cases, it can also produce small pockets of gas in body fluids or tissues in the body, and that's known as cavitation. Now, the long-term effects of tissue heating and cavitation are not known. However, there are no known negative bioeffects that have occurred because of ultrasound. But because of the particular concern for fetal exposures, the national and international organizations have advocated prudent use of ultrasound imaging. So furthermore, the use of diagnostic ultrasound for non-medical purposes, such as fetal keepsake videos, has been discouraged. Now, we know in the Pregnancy Resource Center, it's not about keepsake videos, it's not the 3D. We're trying to show these clients what's actually there. We're trying to show them, that it is a little tiny human. There is a heartbeat there. It is moving around. It's got arms, it's got legs. Those are the things that we're trying to show. Okay, and the reason we've got the ALARA principle up here, we'll see that in just a second on the next slide, what that actually means, okay? So ALARA stands for as low as reasonably achievable. So this is an acronym, or a phrase that's used in x-ray a lot of times because they want to reduce the amount of radiation that goes into the body, or just reduce the amount of patient exposure. Now, even though ultrasound is completely safe because there's no proven bioeffects yet, we still want to be using it prudently, because we are scanning an area that is very small and also has lots of developing cells within it, right? The embryo, that little baby in there, has got lots of tiny cells that are rapidly developing. So we want to know what we're doing, okay? So just a little brief introduction of the intensity of ultrasound beam. It is equal to the power divided by the area. So if the power of the ultrasound beam remains the same and we reduce the area that we're channeling that power into, then that means the intensity is greater in that area. So this is a lot of words that we're not used to dealing with. So I've got this picture here because we can all sort of relate. We can all think back to a time when we were little and we had the magnifying glass and we were trying to catch something on fire, right? Maybe not catch it on fire, but just see if we could heat something up, or concentrate that light of the sun, that light energy, into a smaller area. So the power from the sun, that light energy, doesn't change. But if we use that magnifying glass and we concentrate it into a small little area, then in that small little area the intensity increases enough to catch fire, right? So same sort of understanding when we're scanning a little baby that's 6 or 7 weeks, and we use the ultrasound and we concentrate it into an area. Now there's a couple of things that are on this slide that does use a little bit more ultrasound power, okay? So we've got more power when we use color Doppler, which is right here. We can see this is the embryo, that's its little bottom, that's its head, and then here's the blood flow throughout. Okay, so we're able to see the blood flow. And then here they're using pulse Doppler. This is where we can actually hear the heartbeat. So these two modes of ultrasound does have an increased power. So when we have an increased power in that small, tiny little area where the embryo is, you know, that's not ideal, because the things that we need to do by like just scanning and showing what's there without adding the color, without having to listen, we can still show the mom what's there without having to use that increased power. So the only time we would want to use the pulse Doppler is because if the patient is abortion minded or abortion vulnerable, and we really feel like that can help them connect to that baby. Okay, that's the only time we would want to use that before 14 weeks. Now after 14 weeks, it's not as frowned upon to use it, but only in diagnostic purposes do they use these things out in the field of sonography before 14 weeks. And because we are not diagnostic at pregnancy resource centers, we want to, kind of eliminate the use of color and eliminate the use of pulse Doppler unless it is necessary. Okay, what we like to use is called M mode, and the M stands for motion. This is what the American Institute of Ultrasound and Medicine says is best and safest to acquire that heart rate. Okay, so the fetal heart rate. And as you're doing your clinical scans with your RDMS or your nurse supervisor, they can show you the proper way to utilize the M mode to be able to get the heart rate. But this is by using the ALARA principle, as low as reasonably achievable, we want to make sure that we use the lowest amount of power so that we reduce the intensity in that small area that we're scanning. So artifacts. When we think of artifacts, we typically think of, Egypt, the pyramids, things that we dig up, dinosaurs, things like that. But in sonography, artifacts include anything that doesn't correctly display the structures or the functions imaged. So an artifact is caused by some problematic aspect of the imaging technique. So certain assumptions are made with our machines, like that the sound is traveling in a straight line, that another assumption that is plugged into our machine is the propagation speed of soft tissue. There's lots of things that our physicists plugged into our machine that we don't have to think about. But when those assumptions are irrelevant, then artifacts occur. So some artifacts are helpful for us, not only in imaging, but in diagnostic ultrasound as well. And then some artifacts get in our way and cause imaging to be difficult. So two of the artifacts that we will discuss in this presentation are enhancement and shadowing. Okay? Now, if you've had a chance to watch some of the scans, then you probably are familiar with what these two artifacts look like. But if you haven't, it's nice to have this introduction so that as you're watching, observing the scans and doing your hands-on scans, that you'll be able to pick up on what these artifacts are and how you can utilize enhancement to your advantage. So enhancement artifact appears as hyperechoic region. So I'm going to take a brief moment here because I haven't explained some of these sonographic terms. So if you have a pen or pencil and paper and you want to write this down, there's a couple of terms that you need to know. So hyperechoic means that there's an increase in the echoes. So if something is referred to as hyperechoic, then it means it's going to be brighter on our screen than the structures around it. Okay? Hypoechoic means that there are less echoes. So it's going to be a little darker on the screen than the structures around it. Okay? Another word is anechoic, A-N-E-C-H-O-I-C. So anechoic means that there are no echoes. So it will be completely black on the screen. So if you look at the image over here on the right, this is the bladder, and it is considered to be anechoic because there's no echoes being returned from within the lumen of the bladder. So all of this is fluid, all right? And so enhancement artifact appears as hyperechoic region beneath tissues with abnormally low attenuation. So another word here, attenuation, that means the dampening or weakening of the sound. Okay, so because the bladder here is full of fluid, full of urine, there's not as much attenuation or weakening of the sound, so it makes what's beneath it brighter. So we can see here, this looks like this little golf putter. Okay, so this golf putter right here, this is the vaginal canal, this is the cervix, and then we have the uterus here. All right, and so this is the fundus of the uterus, this is the body of the uterus, the lower uterine segment, and then the cervix. We can even see the cervical os here, and I'm going to follow it into the endometrium with this red pointer. So here, going through the cervix, now we're in the endometrium, so right in here. And we know that in a pregnancy, we want to see the implantation usually in the fundus. That's the place it should be. So if we had an intrauterine pregnancy in this image, we would want to see it right here in the fundus, okay? So a full bladder is ideal when imaging the uterus, not only because it tilts the uterus back where we can see it better, but it allows more sound to reach the area of interest right here. So this is a patient with a full bladder. Now I will say at pregnancy test centers, you're usually not going to get a patient with a full bladder unless they have been scheduled to come back for their ultrasound. And that is because usually they're taking a urine pregnancy test before they're coming to you. So very rarely will you see one that is just perfectly full like this. But this is a patient with an empty bladder. So here, where we can see the vaginal canal and the cervix into the uterus, this is the vaginal canal here. Okay, there's a little bit of, looks like mucus within that vaginal canal. That's what that's pointing to. Here is the cervix. And then here, I'm outlining the fundus of the uterus. So this is the uterus right here, including the cervix down here. Whereas you can see up here with the full bladder, it's nice and extended out, and we can see it better. So on this slide, we're talking about enhancement. And remember, enhancement is an artifact, and it's to where there is more, there's less attenuation, so we can see more of what's beneath that low attenuating structure. Okay, the second artifact we'll talk about is shadowing. Okay, now shadowing affects us a lot because shadowing appears as a hypoechoic or even anechoic, remember no echoes, region that extends downward from a highly attenuating structure. So remember, attenuation means weakening of the sound. So some things that are within the body that have high attenuation are bone and bowel gas. Okay, so we can see this is labeled bowel gas. This is a picture of the liver, which is not something you're going to be scanning, but it gives us a good demonstration of bowel gas with shadowing. So if we're scanning the pelvis because we're looking for an intrauterine pregnancy, we know there's lots of bowel down there. So if they're a very gassy patient, you may have to work around bowel gas. So shadows appear when the attenuation is very high. Attenuation is high in air. So we have lots of issues with the bowel gas. Okay, that's it for attenuation. Now I want to talk a little bit, just briefly, about receiver functions, okay? So in sonography, let's see. Nope, let me go back. Okay, I mixed up a slide there. So our receiver, it has lots of different functions that it does when we're trying to make our image better, and we're twisting buttons and we're moving, sliding buttons over on our machine. Once we start getting the hang of things, you know, it makes our image brighter or it makes it darker. all of those adjustments are being made in the actual receiver of the machine. So the receiver gain is how we adjust the brightness of the image. Now this does not increase the power of the sound that is entering into the body, okay? There's another way that we can adjust that, but for your purposes, you don't need to mess with it. You need to just worry about the receiver gain. And that's going to be different. It's going to be a different button on each machine depending on where you're at and which machine you use, but usually it is a turn knob, okay? Sometimes it's a flick up and down, but usually it's a turning knob. So adjusting that receiver gain alters the strengths of the voltages in the receiver. So once the echo has come back and it's displayed our picture on the screen, we're just adjusting the echoes that have come back, not what's being sent out, okay? So if you have too much receiver gain, your image will be too bright, like it is up here on the top, and if it's too little, it's going to be too dark, okay? Now again, this up here is an image of the spleen. This is an image of the liver. Now you're not going to be looking at these things, but these were good images to kind of demonstrate that receiver gain when it's too high and too low. Okay, so that is the first function that you guys will be learning about that occurs in the receiver. And the second one that I want to talk about is time gain compensation. Excuse me. That's also known as TGC. Now you can see here on the side that it's little sliders. Now a lot of times they'll be in a line like this, but the function of the TGC is to equalize the differences in the received echo. So to put that in layman's terms, imagine that this is the top of your screen and this is the bottom of your screen, okay? Your screen being the ultrasound machine screen. So we're looking at our image. If the bottom of the machine, or if the bottom of the image is too dark, if we slide these little sliders more to the right, then it makes it, excuse me, it makes it brighter towards the bottom. So when we slide these sliders to the left, it makes that area darker. And remember, this is the top of our screen and this is the bottom of our screen. So usually you're not going to need to use this compensation until you get a little bit further down, and that's just because of the way the sound weakens as it travels into the body. So just remember that if you have an image that it's really dark at the bottom, you don't want to use the overall gain, because it's just going to make, if you turn it up, it might make the bottom where you need it to be, but then the top's going to be way too bright. So using these sliders allows us to make the bottom of the image brighter without adjusting the top. Okay, now again, depending on where you're at, you may use a sonosite. I know some of the facilities may use a Sono Ace R7. There's Samsung, there's GE, there's Philips, there's Esaote MyLabs. You know, some of the mobile facilities may have more of a sonosite or MyLab Gamma setup, so it's like a smaller version, like a little laptop, but it's going to be on a cart. But if you're in a brick and mortar facility, you're usually going to have a larger machine to work with. So you'll talk with your nurse supervisor or your RDMS to be able to show you knobology, so where all the buttons are and what they do. Okay, most facilities are going to have these purple top sandy cloth wipes. Use these after each patient. Okay, wipe the ultrasound transducer gel off the transducer, and then you're going to get these sandy cloths and disinfect it. Do not just disinfect the top, but use the cloth to also disinfect the cable of the transducer as well. You'll allow this to dry, and it is effective after 2 minutes. Okay, and then there's the MSDS sheet if anyone needs to access that. So this may be one of the policy that varies depending on what facility you're at, so you want to make sure that this lines up. But for most facilities, we will not scan a client if they have had the following. So if they have had moderate to heavy bleeding at any time during their pregnancy, we will not scan them. Severe cramping, those are things that can kind of suggest an ectopic pregnancy, which is something that they would need to see a physician about right away. And we're not diagnostic, so we want to make sure that we do not kind of blur the lines there. So we do not scan patients that have had those symptoms. We will not scan them before 5 weeks or above 22 weeks, or if they are under the care of a physician, because that's going to be a conflict of interest if they're already receiving physician care. Before 5 weeks, even though it's there, it's very difficult. You cannot see the embryo on ultrasound, even transvaginally, before that 5-week mark. And honestly, I would suggest 6 weeks being that line, because you wouldn't want to show someone an ultrasound image and not be able to see the baby and then think that, oh, it's not there. Okay, so it's just best to kind of follow the guidelines of the facility that you're volunteering at. Okay, and above 22 weeks, that some places it's 20, some places it's 24. It really just depends, but typically by that time they are under the care of a physician. We do not diagnose and we do not reveal gender. That may vary at some of the facilities, but as far as the diagnostic portion, we do not diagnose. It is a limited OB ultrasound. So now I want to get into some of the normal pelvic structures that you may or that you will encounter. You'll definitely encounter a uterus if they're pregnant. You may or may not see ovaries that we're going to talk about in a little bit, but if they are pregnant, you will see a uterus. So here's just a nice schematic. Here's the transducer on the lower part, or the upper part of the pelvis, and this is, showing that sound waves going in. So this is showing the image. And if you've ever seen a CAT scan, so that's, slice by slice that machine takes and gives tons and tons of images. Well, with an ultrasound, we are taking a thin slice of the anatomy. Okay, so this provides a thin slice. So this is a thin slice, just like it's picked up and it's put on the screen. So where the transducer touches is going to be the top of the ultrasound screen image. And then the bottom is going to be opposite of that. So because we're scanning the abdomen, we're scanning the anterior portion of the patient, the anterior is going to be at the top, the posterior is going to be at the bottom. Now on your transducer, there's going to be an index, and your nurse supervisor or sonographer can show you where that index is. Now the index, if you are scanning in a sagittal plane, which is up and down, right, the index needs to be pointed towards the patient's head. Okay, so the index pointed towards the patient's head, that means the index is going to be on this side, and that means what is on this side of the screen is superior, and what at the opposite side of the screen is inferior. Okay, now this is something that my students usually have the hardest time grasping right away. So if it doesn't just click right away, don't worry. The more you scan, the more this is going to make sense, and it will become just secondhand to you to be able to pick things out and realize, oh, I need to move up or down or side to side to get that image a little bit better than I've got it. Okay, so anterior, posterior, superior, and inferior. This is in a sagittal plane. So this is an actual ultrasound image of the schematic that we just kind of saw. So this is a large full bladder. So this is the anterior portion of the patient, and then the sound goes down. This is posterior. All right, so if we think about it, that means the bladder is anterior to the uterus. The uterus is posterior to the bladder. Okay, and because our index is pointed towards the patient's head, when we're in that sagittal plane, that means that this is towards the patient's head, this is superior, and then this is towards the patient's feet, inferior. So the reason that we want to know that is if we're wanting to get this a little more centered, if we're wanting to move this uterus a little more to the left of our screen, we're going to have to angle the sound more inferior, so angle more towards the patient's feet. So this, you may, at your facility, you may be required to take midline pictures, right and left. This is just a standard protocol for a more diagnostic lab, so you may not be required to have all these images. I just like to put these in here just in case. Okay, when we are in a transverse plane, notice that the index, it's got a little star here, the index is pointed towards the patient's right side. So you are usually going to be, you're the sonographer, you're going to be standing on the patient's right side. So that index will be pointed towards you. Okay, but notice the top of the screen is whatever the transducer's touching, and that's going to be anterior, just like it was in sagittal. Posterior is going to be the same again. So this is where it gets a little bit tricky when you are learning what's on the screen and what direction, because remember that index is pointed towards the patient's right, which is on what side of the screen? Okay, if we're looking at the screen, that's on the left side of our screen. So this becomes right and that becomes left. So, us sonographers, we're not really good at keeping our right and left straight. Typically, if I tell my husband, oh yeah, turn right, a lot of times I mean my patient's right, so it's left. So that's something that it takes a little getting used to. So in transverse, you may be required to take these images, but again, this is more of a diagnostic approach, and we're not doing a lot of diagnostic ultrasound here. We're just wanting to see, where the baby is and get fetal heart tones and be able to show the mom, okay? So this is what the uterus looks like in a transverse plane. So remember, it's just a thin slice, transverse plane, and this is the endometrium. So if this patient were pregnant, we would see that embryo in here. Okay, now sagittal. This is the cervix in a sagittal plane. Now this is a patient that's pregnant because we've got a baby here. I can't see much of it, but I would guess this is definitely into the second trimester. This is a bladder. It's got a pretty good amount of fluid in it. Here's the vaginal canal, and then this is the cervix. I could not find a very good image of the transverse cervix, but when you are doing your clinical scanning, if you'll have the sonographer show you the cervix, there's a landmark there. It looks like catfish whiskers, and it's just some shadows that go down from the cervical os on each side and just kind of shadow down. So you may be able to see that in a transverse plane. Okay, the ovaries. This is a very good image of an ovary. Now this is an endovaginal scan, so when we scan endovaginally, we're going to be able to see a lot better. But, your patients, if we can get a good image of the baby without doing an endovaginal scan, that's typically more comfortable for your patients, okay? So you may or may not be doing a lot of endovaginal scanning. Again, this is endovaginal scan, and we can see the ovary here. There's lots of little anechoic circles. Those are just normal functioning follicles, okay? Over here, this is a transabdominal scan, and it's transverse. We can see the uterus right here. This is the bladder. It's a full bladder, and we may even actually be more in this close to the cervical area, because this is kind of that catfish whisker look. See, there's a dark line, but this is the endometrium. So you're kind of getting some shadowing from the side there. But this is the right ovary, and this is the left ovary. Okay, now this has got a very large complex cyst in it, but again, we do not diagnose, so that's not important for you to know exactly what it is. But I like to kind of include these images because you're going to run into a lot of things, and you kind of need to, be a little familiar with some of the things that you're going to see. Okay, so I want you to just take a moment and pause the video, write down any questions that you may have up to this point, and if it's something that needs to be passed along to me, I can help answer those questions, or your nurse manager or sonographer can answer those as well. Okay, now we're going to get started on session 2. This is where we're looking at the fetal evaluation, looking at the development, and also the measurement of the fetus. I do like to just briefly cover, conception and kind of what we're called. We're not going to get into a big, human anatomy and physiology lecture, but the ovum, that is the egg that is ovulated from the ovary. It goes into the fallopian tube, and typically within the fallopian tube is where conception occurs. Okay, once conception occurs, we are known as a zygote. Okay, those two cells, they are there, they've combined, or we've had the two gametes combine, and then we have cells that start to multiply and split, okay? And it splits enough to where we kind of look like a little mulberry. And morula is what we're referred to as. And then we drift down, we get into the endometrium, and then we're big enough and we blast into the side of the endometrium. When we blast into the side of the endometrium, we're known as a blastocyst, okay? And implantation, because it is sort of a, it's blasting into the endometrium, there can be a little bit of bleeding. So sometimes you'll have a client come in and you ask them when their last menstrual period was, and they'll say, oh, well, it was, 5 weeks ago, but it wasn't a normal period. It was, I just bled for like a day or so. That may have been implantation bleeding, and if that's the case, the patient may be further along than their dates suggest. So that's where you're, kind of client to client, figuring out who may be further along. You may want to offer them an ultrasound sooner than the dates show. That's just going to be up to your nurse manager. Okay, once we're implanted into the endometrium, we start to grow very rapidly, okay? So there's a little yolk sac that we see here. That yolk sac, you should be able to see that before you even see the embryo, okay? The yolk sac is what is providing the nutrition, lots of other things, but we just like to tell clients that's what's feeding the baby until the placenta forms, okay? And then we just continue to grow here to there to there to there, and that yolk sac goes away by 12 weeks. So if you see an embryo or you see the fetus in there and there's no yolk sac, before you even do measurements, you can say, okay, there's no yolk sac. We know they're at least 12 weeks along. So here's some normal embryologic development. One thing that I really think hits home with everybody to understand how quickly we all develop in utero is that the heart begins to beat 23 days after conception or after fertilization, okay? So usually before the patient even knows they're pregnant, the baby already has a heartbeat, okay? By week 10, all of the organs are formed, okay? They're all formed in their early stages of development. They've just got to continue to grow. So everything is in place. It's just got to continue to get bigger. And then here's some other things if you want to pause the video and kind of read. It's pretty cool. Another thing that I don't think it's mentioned on here, but the fingerprints, our fingerprints, everyone's are unique. The way we get those fingerprints is that as we touch the amniotic sac when we're inside our mom, that causes little folds to develop on the ends of our fingers. So that's how we get our fingerprints. I thought that was a pretty cool thing to learn. So if you haven't read these, go ahead and pause it and then unpause, and we'll go to the next slide. Okay, so here are a couple of slides that we're going to skip through and just kind of briefly look at again, but if you need to pause it to look at it in more in depth, we've got a lot of side-by-side what you expect to see at each week in ultrasound, okay? So by embryoscopy, this is what we can see, the little embryo here, and here's the yolk sac. This is that amniotic sac, okay? On ultrasound, though, around 6 weeks, this is the yolk sac, and this is the embryo. It's a tiny little peanut in there, okay? And then this is that gestational sac. We'll learn more about how we're going to identify these things and measure them, but I just like to give these few slides of introduction because it's just kind of cool. So here we can see that embryo, and then on ultrasound, this is what it looks like. Okay, it's just a little shrimp, tiny little shrimp in there. Sometimes they'll look like a little gummy bear around this time because they've got that big head and they've got those tiny little arm and leg buds. And then we can see right here, this is just a normal gut development, you know, right here, and then we've got the heart back here. By 10 weeks, you know, this is a really sad picture, but I wanted to include it because it is just so detailed that we can see the fingers, you know, and remember by 10 weeks, organogenesis is complete. All of the organs that are going to be in that baby are there. They've just got to grow, mature, and continue to get to where they're functional. So we can see the little eyes, little ears. And then on ultrasound, we can see a little leg bud, arm, there's the head, there's the little bottom, and then it's all contained in this gestational sac. And then this is the uterus that I'm outlining here. Oh, that's the uterus. Okay, by 12 weeks, notice it's starting to look a lot different, right? It's not looking like that little gummy bear anymore. We can see a good profile there. There's the forehead, the nose, the lips, the chin. That's a little pokey out belly. There's a leg. And then we can see with a scope, we have images, we can see those fingers really well. You can see the vascular structures within the skin. By 14 weeks. Now these are both ultrasound pictures, but this is an HD live image. So it's got the light aspect added to that 3D imaging. So your facilities probably do not have something as advanced as this, but you know, you may be lucky and have something. You may be able to get some of these really cutesy pics. But we can see really easily, you know, all the different structures, external structures. And then using the 2D ultrasound, we can see there, right here, that's the maxilla. There's the chin, there's the nose, the frontal bone. You can see all kind of, this right here is the stomach. At 16 weeks, the scope. And with ultrasound, we can see the vertebral column really well. See all the vertebrae. 18 weeks. This is an illustration. It's just to show that, you know, it's just starting to gain in length. See a cute little profile there. Here's the fetal heart. Okay, this is a diaphragm here. This is lungs. This is the fetal liver. And obviously this is fetal brain. Now this right here is the placenta. Now again, we're not doing a lot of diagnostic, we're not doing scans that are diagnostic, so we don't have to look and evaluate placenta and all of the fetal organs, but it is nice to know, you know, what some of the things are that you can point out. So this is at 20 weeks. Look at that little ear, how developed it is. Here at 20 weeks we can see, now this one is a little bit bright. We can see we might want to turn the gain down, but it gives us a really good profile, a facial profile. This is the heart. There's the spine. That's a piece of a hand coming in there. This is umbilical cord. At 22 weeks, this kid is going to be a little gymnast. It always amazes me that you can see them, you know, wrapped up like they are. But it's got its legs stretched out here. Its head is down here. And this says 22 weeks. Now this scope image is probably, this baby's probably a little closer to like 26 weeks because it's starting to get a little more plump. They're usually not as plump in the face at 22 weeks. You may run across patients that are pregnant with multiples, okay? So this is twins. Over here I have an image of triplets. We've got two that are in the same chorionic sac, so same gestational sac, and then one that's in its own sac. But then we see this line right here. That's an amniotic sac. So these two babies even though they're in the same gestational sac, they're not in the same amniotic sac. So that's not super important for you to diagnose, but sometimes it's nice to just see that they've got their own little headquarters, okay? I threw this in just as an FYI. It depends on the time of cleavage or the time of separation after fertilization of twins as to if they're going to have their own amniotic sac, if they're going to share a placenta, they have their own gestational sac, things like that. But if they separate 13 days or more after the fertilization takes place, then you will have conjoined twins. Okay, so 2 measurement techniques in the first trimester. We're going to go over those. And then the second trimester, I believe I have those in here, but if not, we'll be able to kind of go over those with your nurse manager. Okay, so first trimester, the 2 measurements that you'll be looking to do are the mean sac diameter and the crown rump length. Now, I will say before we get into these images that the mean sac diameter, it is one that we do when we cannot see an embryo. So they're really early along and the embryo is not large enough to see, then we will do the mean sac diameter. Once we see the baby, once we see the embryo, right, we will do the crown rump length. And you'll know what that means here in a little bit, okay? Now in the second and third trimester, if you do have patients, well, you won't have them in that third trimester because you're usually not going to scan past that 22 week. But these are the 4 measurements that you can do. These are biometric measurements, so they are, if you get the correct measurement using the right landmarks, they're good estimations of the gestational age. However, your facility may not use all of these in the measurement. Okay, they may just use BPD and femur length, or they may just use head circumference and femur length. So you do whatever the nurse manager says is the protocol for your facility. Okay, so in the first trimester, so 0 to 12 weeks, the gestational sac size is something that we look at when we do the mean sac diameter, okay? And this measurement is going to correlate really closely with menstrual age and early pregnancy, but this measurement actually, it's accurate through week 8. But if you remember earlier in the presentation, I said usually we start seeing that embryo around week 6. And once we see the embryo, we do not use this measurement anymore. We just do the crown rump length. So the gestational sac, the mean sac diameter is determined by the average sum of the length, width, and height of that gestational sac. So this is a very poor ultrasound image. You may not know it because you've not looked at a lot of them, but this, trust me, this is an old image, but it gives us a good caliper placement. So these are calipers right here that we use to measure. So this is a sagittal sonogram. And I know it's sagittal because they told me right here. Otherwise, I wouldn't know. So this is a sagittal ultrasound at around 6 weeks. Okay, this is the gestational sac right here. And we measure inner to inner, okay, when we're measuring the gestational sac. So this is the inside of the gestational sac. This here is the yolk sac, okay? So notice on the side over here it says the length, the width, and the height. So you have to think about this in a 3D sort of way because we're getting a volume. So we take the sagittal picture and we do the length, which is this way. We do the height, which is anterior to posterior. And then we would take a transverse picture and then we would do the width, which is the right to left. Okay, so on this next image we'll be able to see 2 actual pictures of the same, this is a better image, okay, of the same gestational sac. So here we have a longitudinal image, so a sagittal image, gestational sac. So this is the length, inner to inner. This is the height, inner to inner, right? Now this is superior to inferior. This is anterior to posterior. And if you need to pause it just to kind of think about that, I encourage you to do so. Over here is the transverse image. So this is the transverse image, and it's side to side, okay, right to left, and this is the width. So by using our machine in the calculation package, it will plug all three of these in and go ahead and give us the gestational sac size, which is 2.7 centimeters, and that correlates, it looks like 7 weeks and 3 days. Now this is a good image for the mean sac diameter. However, this, since it's 7 weeks along, there's no embryo in here, so this is going to be one of those anembryonic pregnancies that we'll talk about later on. But again, this mean sac diameter measurement, it's not widely used to determine gestational age because the crown rump length that we're going to talk about now is the most accurate method for dating a pregnancy. Okay, this is more accurate than even the last menstrual period. As long as you measure it correctly. Okay, so it's really important to pay attention to the lengthening out of the embryo so that you can place the calipers on the right portions. Okay, so crown rump length is pretty self-explanatory as to where we place the calipers. Okay, so this is the baby's head right here. This is the baby's bottom, or the rump. Okay, we've got it good and stretched out, and we put a caliper at the top of the head and a caliper at the rump. Okay, so that's crown rump length. So this should be used until about week 12. And there's that 12 to 14 week time frame that is just kind of a difficult time to measure from a sonographer standpoint of view, because it's difficult to see the landmarks to do those other 4 measurements, the head circumference, abdominal, femur length, but it's too far along to do the crown rump. So you kind of hope that it's under 12 or over 14 when you have those clients come in. Just another FYI right here, the rule of thumb is that the crown rump length in centimeters, we can add the number 6 to it, and that's going to tell us the gestational age. So right here, excuse me, right here we have the measurement actually is 2.9 centimeters or 29 millimeters. So if we add 6 to this, now we add it in centimeters, we can see right here, centimeters. So 2.9 centimeters plus 6 is going to give us 8.9. And it tells us that it's an 8-week embryo. So this is between 8 and 9 week embryo. We can tell that without even looking at the calculation of weeks. But good thing we don't have to memorize that because our machine will tell us in how many weeks, okay? So this is a magnified image. This is the head right here. This is the bottom, the rump. And then this umbilical cord looks massive, but it's just because the baby's so small, okay? It's not small on the screen, but it's small in the body. So if we were doing a measurement, we would place a caliper right here, and then also right here, and that would give us a crown rump length. Okay, this is another one. It's a little bit further along, but the number 2 set calipers we see are measuring at the crown and at the rump, okay, and that is crown rump length. Now the number 1, it's measuring the nuchal translucency, and this is something that is a diagnostic parameter, so you guys don't have to worry about that. I just wanted to mention it in case you were wondering what the 1 was measuring. So the crown rump length, we've got the baby stretched out really well, and it's measured there. Okay, some of the sonographic landmarks in an early pregnancy. I want to just sort of mention these because as you start scanning, everyone is going to look a little different, okay? No one client is going to look the same. Now, the more you scan, the more things will start to look the same because you'll start to recognize things, okay? But in the meantime, I want to just sort of introduce you to these terms. So, double decidual sac sign. So, the decidual reaction is just when the endometrium becomes impregnated with that blastocyst, okay? So, once the endometrium is impregnated by that blastocyst, then it becomes the decidua. So that double decidual sign is the two layers of the decidual reaction. So we've got here and then another layer outside there. So really just this thickened white area, okay, thickened white area, that is the double decidual sac sign, okay? And remember, it's going to be anechoic inside, and that's fluid. So the yolk sac should be seen. We can see the tiny little yolk sac, looks like a Cheerio. That's called the Cheerio sign. And the embryo, if we are scanning with an endovaginal probe or transvaginal probe, then we should be able to see it by 6 weeks. We can see it transabdominally that way as well. This says that there is a 4-week gestation seen. However, we will usually never see that embryo at 4 weeks. So honestly, I feel like this is more of a 5 to 6 week, because we can see the yolk sac and we can see an embryo. So the gestational sac, which we see here with the double decidual sac sign, we see that at 4 weeks. That's our first indicator of a possible pregnancy. Now the yolk sac we should see by 5 weeks. So this would indicate a normal IUP, intrauterine pregnancy, okay, because it's in the uterus, it's in the fundal portion of the uterus. And you're probably thinking, how do you know it's the fundus? It doesn't look like that last one we saw. Well, this is an endovaginal scan, okay? So it's going to be a different sort of orientation. It's just going to take some getting used to scanning, okay? And then this is a transverse image. We can see an ovary over here, some over here, but honestly, this may be also some vascular, some of the uterine vasculature. Okay, this is another zoomed up image. And remember when I said make sure when you're doing that crown rump length, or I may have not said, if I haven't, here I'm saying it now. So the yolk sac, we want to make sure we do not include that yolk sac in that crown rump length measurement. So this is the embryo here, and again, I know this is a very difficult image to kind of see, especially since you're just starting to learn what ultrasound looks like. But it's just because it's really magnified. But this is the yolk sac that it's pointing to. All of these arrows are pointing to the yolk sac, and then the actual embryo is here. So you would not want to include that yolk sac in that crown rump length measurement. Remember, it's the crown to rump length. And so if we look here, it tells us that the measurement is 0.73 centimeters. Now remember, if we add that 6, we have 6.73, and that tells us that they're between 6 and 7 weeks along, okay? And it also says right here that's consistent with a 6.5 week gestation. Okay, here's a transvaginal image of an 8-week gestation. Now if we were doing the crown rump length, we would put the measurement here on the crown, and then the rump right there, okay? So that would be crown rump length. And because it tells us it's an 8-week gestation, and we know we add 6 to centimeters, we could actually kind of reverse that, and you could guess that this measurement is going to be about 2 centimeters, okay? So if you think about that for just a second, an inch is 2.54 centimeters, okay? So just shy of an inch is how big we are at 8 weeks gestation. So that's kind of cool to think about. It's about the, the length of the thumb. So that's a tiny little thing in there, and that's just 2 more weeks before all of the organs are completely developed. Okay, this is just another schematic, just reiterating where we place those calipers. Remember, it is the most accurate measurement technique using ultrasound during that first trimester. Here's another image. I'm not going to stop on these too much, but this measurement is 6.09 centimeters. If we add 6 to that, we get 12 weeks, okay? And then it tells us down here that's 12 weeks and 3 days. Another transverse image. Now this is an endovaginal scan, okay, and this is a transverse image. This is a very large gestational sac. Now you're not supposed to know that right now, but I've been doing ultrasound a while, and just by eyeballing this I can say, oh, that's kind of a big gestational sac for such a small embryo. Well, this is an 8-week fetus that they've measured, and there's no cardiac activity identified. So this is a fetal demise. So that's what's happened is the baby passed away, but the sac continued to grow. Okay, so that's why it's a little disproportionate. Okay, so the fetal heart rate acquisition, remember with the ALARA principle we talked about, we would not want to use the pulse wave Doppler, okay? We would want to use the M mode. Remember the pulse wave, that gives us the ability to hear it. It gives us that audible aspect. So if you do have a client that is abortion minded, by all means, if you feel like that heartbeat, hearing that heartbeat is going to help her connect to what's really there, then that would be much more or much less harmful than an abortion, obviously. So we never discourage you from using this in situations like that. However, if you have a patient, have a client that comes in and they're excited, they're not abortion vulnerable in any way, we want to use that M mode. And if they're concerned about, well, why can't I hear it? Just say, well, it's just safer if we use this for now, and then when you get further along, when you're at your doctor, they'll allow you to hear it. But you can point out, if you didn't have this on there, you can point out the, flicker, the back and forth movement of the heart so that they can see that visually. Okay, again, I want you to pause here and write down any questions that you may have. Okay, in session 3, we're going to have the empty uterus challenge. So really, this is just kind of giving us some ideas of what we may see that could be issues, right? So just as a reminder, we're going to look at these normal pelvic structures just one more time, okay? We're not going to look at a lot in detail, but again, remember transducer is anterior, so we're looking in sagittal plane at that uterus. We also want to do a quick survey through in the transverse plane. Okay, so we turn that index, which we'll be able to find on our probe, we turn that index towards us, which is the patient's right. And we should be able to get a good transverse image. The cervix, again, we can see in a sagittal plane and a transverse plane, and also we may see some of those ovaries. But we can run across some pathologies. Okay, so I'm going to briefly describe a common gynecologic pathology that you may see, and that is uterine fibroids. Okay, uterine fibroids are just smooth muscle tumors. They're typically benign. They're known as leiomyoma. They are the most common gynecological tumor. They can occur anywhere in the uterus, in the cervix. They can even be what's known as a pedunculated fibroid and kind of hang off of the uterus. So remember, we're not diagnostic, but if we see something, we kind of want to not be taken aback and realize, oh, that's probably a fibroid. Okay, you will see things that you're not expecting to be there. These fibroids occur in approximately 20 to 30% of women over the age of 30, and they are more common in the African American population. Now, estrogen dependent, they are estrogen dependent, and which means they can increase in size during pregnancy. Another common gynecologic pathology that we can see is cysts. Now, cysts are just fluid-filled structures. There's common cysts that occur in the ovary. Let's see if we can look at some of these things here. So we have, this is an ovary right here. This is a cyst, and that is a cyst. Sometimes you can have a large cyst that may hemorrhage. If it hemorrhages, it might have a little bit of debris or kind of echoes within it. But we can also just see normal follicle cysts that are just normal physiologic things that we're supposed to have, okay? So these are ovarian cysts because this is an ovary that I'm outlining here. But this big cyst over here, that's a para-ovarian cyst. So para-ovarian just means that it's around the ovary. Here we have a large adnexal cyst. Excuse me. So adnexal just means the region outside of the uterus. Okay, so here this is an endovaginal scan. This is a cervix going into the uterus, and these are little cervical cysts. These are known as Nabothian. Okay, when you see cyst within the cervix, those are Nabothian cysts. And there are endometrial cysts that can occur, and those kind of are tricky because we may confuse those for a gestational sac. But if we look around that cyst and we do not see that bright white, that double decidual sac sign, then we know that's probably not a gestational sac. That would be an endometrial cyst. Okay, some obstetrical pathologies, and again, we are not diagnostic. However, we may run into some things that, or one thing in particular that is an emergency and that we do need to refer them to the ER or a local physician. Now, that may be something that you need to talk about your medical, or talk with your medical director or your nurse manager on how to handle suspected ectopic pregnancies, okay? But it is important, if we recognize it to be an ectopic pregnancy, that we have a protocol in place so that we know how to handle that situation, okay? An ectopic pregnancy is the only emergent diagnosis that requires you to either refer that patient or get in touch with the physician to handle that situation, okay? Ectopic pregnancy is when there is a pregnancy located outside of the central fundal location of the uterus. So this is the uterus, okay, and this is the endometrium. We want to see it implanted, that pregnancy implanted in the central fundal portion. That's where it's supposed to be, okay? Anytime we see it outside of this area, that is suspicious for an ectopic pregnancy. So this is a schematic that just shows us the different areas that the implantation could occur that are not where it's supposed to be. So we can have them in the isthmus, that's in the area where the fallopian tube is coming into the, sorry, my mind went blank, into the uterus. There's tubal pregnancies, ovarian, peritoneal, which can also be called abdominal ectopics, and then also the cervical ectopics. Now, usually these occur in patients that have had a previous history of a C-section, and they may have an implantation into that cervical scar. Okay, so it's important to know your client's pregnancy history. So pregnancy located out of that, approximately 10% of maternal deaths are related to a ruptured ectopic. That's why it's so important to, have that protocol in place. Some things that can increase the patient's risk of an ectopic pregnancy is if they have had a previous ectopic, if they have had previous pelvic surgeries, whether it be abortions or some sort of gynecologic procedure, D&Cs, if they've had any pregnancy loss, any C-sections, also if they have had history of STDs, pelvic inflammatory disease, anything that can cause scarring, if they've had endometriosis or have endometriosis, all of those things are risk factors for developing an ectopic pregnancy. So, I know that kind of worries you and you're like, oh no, what if I miss something? Remember, we are not diagnostic, okay? We are there just to show the heartbeat, the baby, show the mother what's there. But if we see the pregnancy outside of the uterus, we go into the mode of taking care of what we need to do as far as that protocol goes. So this is an ectopic pregnancy shown by endovaginal ultrasound. So here's an ovary. This is the pregnancy, okay? So this is the gestational sac. There's the baby there. And then the uterus is over here, okay? So some of these are more obvious than others. However, if you have a patient that comes in and you have a positive pregnancy test, so these are the things that you need to kind of key in that there may be an ectopic. Okay, number 1, positive pregnancy test. Number 2, empty uterus. So there's no gestational sac in the uterus. Number 3, you see an adnexal mass. So you may see what looks like a gestational sac, or you may just see something that's, large. It's not an ovary, but it's not in the uterus. So those 3 things would be suspicious for ectopic, especially if they may be having a little tenderness on that same side that you see that mass on, okay? Again, we're not diagnostic, but if you suspect an ectopic pregnancy, you need to have that plan in place so that you know how to handle things, okay? So remember that ectopic pregnancy is the only emergency situation. However, you may run into some things that are sad, okay? So a blighted ovum is also known as an anembryonic pregnancy. So I mentioned this a little bit earlier in the presentation. So anembryonic pregnancy means there's no embryo that developed. So it's just a gestational sac. So typically, remember, we're supposed to see the yolk sac by 5 weeks, the embryo by 6 weeks. So this is measuring 7 weeks, and we don't see a yolk sac or an embryo. So this is very suspicious for a blighted ovum. It is not an emergency. You would always want to check for an ectopic pregnancy outside of the uterus, just to see if you see any sort of adnexal mass that looks suspicious. But other than that, this is just a follow-up with your physician, with your medical director physician or the patient's physician, using an endovaginal ultrasound to confirm that, okay? So this is not something that we diagnose. Also, fetal demise, while it is sad, it is not an emergency, okay? And you can see this is the amniotic sac. Here's the embryo, the little baby's head, body, and arm. Now, the reason they've got color Doppler on here is because they're trying to prove that there's no heartbeat, okay? Now, this is not something that you have to do because we're not diagnostic, but depending on your medical director, if there is a fetal demise, if they suggest that you put color Doppler on it just to confirm, that's something that's up to them. But again, not an emergency. They would follow up with their physician. Subchorionic hemorrhage, same thing, not an emergency. They follow up with their physician. Now, what a subchorionic hemorrhage is, here's the gestational sac. There, you can even see they're doing the crown rump length. There's a caliper there, a caliper there. So this is the embryo here. But then we see this anechoic area behind that. So what a subchorionic hemorrhage is just a low pressure bleed resulting from that implantation process, okay? Sometimes it is this big, sometimes it will even engulf the whole outside. The larger it is, the poorer the prognosis, but not something that is, an emergency. Molar pregnancy, again, not an emergency. We would want to follow up with the patient's physician, but the reason I've got it in the slide is because if you see lots of gunky stuff, okay, this is known as like a moth-eaten appearance or a snowflake or cluster of grapes. There's lots of different things, but if you see lots of this in there, and usually the patient will look further along than they actually are, so say they're supposed to be 10 weeks by their dates, but they actually are kind of showing on the outside. They get a little pooch, and you think, oh, they're probably further along than they think. If you put the transducer down and you see this, that is a molar pregnancy, okay? But again, we are not diagnostic. These patients will have an increase in their nauseousness. They'll have what's known a lot of times hyperemesis gravidarum, which is extreme or constant vomiting. and that's because the HCG levels are really elevated because this is a lot of overgrown placenta, which is what produces that HCG. So again, this is just an FYI. And then conjoined twins, not an emergency, but it is when the twin gestation splits after that 13th day. If you can't get, you know, 2 separate heartbeats, or you can't ever get an ultrasound where they're kind of, you know, away from each other, that could be suspicious for that. Okay. Any questions you need to direct to your nurse manager or me, just write them down and let us know. I do not have the landmarks for the BPD, head circumference, femur length, and abdominal circumference in here. So I will make a separate video and kind of point those out and include those and give those to the nurse manager, okay? But thank you for the presentation, thank you for listening to the presentation. This here is actually my daughter, and it's her hand at 15 weeks. She's just waving a little thank you. But here's also my references. If you've got any questions, let me know. You should be ready to start on your 50. If it's 50, some places may require 75 or 100, but at least your 50 hands-on scans with your RDMS or nurse sonographer. And just happy scanning. And thank you for what you do.